So we're going to go ahead and start without Renee Pozza. I'm Anna Hefner. I am a nurse practitioner. I work in Southern California at Southern California Liver and GI Centers. I work with Dr. Tara Kossanine. And I do mostly fatty liver in my clinic. We do see everything from GI to hepatology. And we've each of us took our own little niche into where we wanted to go with it. So that's where we're at. So I do a lot of the hepatology. So Renee's going to join us. You probably heard we were at a funeral. We got here, and so she'll be joining us shortly. Okay? So hopefully we can answer. Do you have any experience with fatty liver disease?
Yeah, I started seeing fatty liver and some fibrosis recently in the office. I was working mostly in the hospital setting for 5 years, but for the past 5-6 months, I transitioned to working in the office as well.
Okay, so is your office a GI hepatology or family practice?
It's general GI.
Okay. So let's get going. Here's the QR to register if you haven't already done that. And so what we're going to do is we're going to really spend some time talking about F3s, F4s. They're very, very similar. Both of them have advanced fibrosis. F4 being your cirrhotic patients that probably need to have a hepatologist associated with them. And so we're going to go through two cases. They'll both be the same person, but we're going to change the numbers so you can see how those differences are. Okay, so first of all, we have Sam. And Sam is a 55-year-old male referred to for mildly abnormal amylase levels and an abdominal sonogram or ultrasound with increased echogenicity, meaning implying that it's fatty liver. And he complains of a lot of fatigue, which a lot of our patients do. We have to remember that fatty liver, unless you're really, really obese, you're overweight, but nobody can really see the fatty liver component of it. So it's just like, oh, you're just fat. Oh, you're just whatever. That's why you're so tired. Okay, so he's 55, he's Caucasian, he's a male, and he has a BMI of 33, which says he's obese. So then we go back and we look at his medical history. He's a type 2 diabetic, he has hypertension, he has hyperlipidemia, he has sleep apnea, he doesn't use any alcohol at all. So now we have the metabolic or the MASH component of it, of this. He has an obese abdomen. He has no stigmata of advanced liver disease. And what that is if you look at the palms of their hand, they'll have some, or like kind of like a little bit of rash, but it's really kind of little spotty dots that's all over. They'll also have spider hemangiomas, which are just little varicose veins up here in the upper chest. And if I hold my hands up like this and hold them straight out, but I can't for the purpose of the computer, you'll see them start to drift down, or you'll see them kind of twitching. That's called a staris. So we have that stigmata. And he has no hepatosplenomegaly, which means his liver and spleen are the normal size. He's currently taking lisinopril blood pressure. He's on rovastatin because he has cholesterol issues. He's on Zimtimbi, which is also known as Zidia. And he is on dipagalide, well, I can't say that word, for his diabetes. So we do have a patient that has a bunch of stuff going on. So he's definitely metabolic. You know what? Let me try to do something from the current slide. There, we'll make it different. We look at his vital signs. They're okay other than his weight's high, and we know that he's obese. His liver enzymes are elevated. His ALP is okay. His total bili's kind of pushing it. His platelets are still within normal limits, and his hemoglobin A1C, he's still out of control with his diabetes, but not too bad. His creatinine's okay, his INR, his clotting times are okay, his ferritin, everything's kind of like we're okay. And he's not we don't see anything with the hepatitis panel. We don't see anything related to autoimmune either. Okay, so now we go ahead and we do some fibrosis assessment. We've got 4 different tests that we can do. We can do the FIB-4, which is based on labs. And in our last talk last week, what we talked about is you actually, if you use Epic, which is a computer system that we use for charting, it actually will calculate it out for you. But he is 2.74, so he's an intermediate risk. So we know that he's got something going on. His FibroScan says that he's 11 kPa. That tells us that we've got some advanced fibrosis. He has a CAP score, which is the fat score of 262. Anything over 250 is steatosis, moderate steatosis up to severe. And he has a blood ELF test, again, another test that we look at to see where he fits on there. And he just makes it into the severe. So we know that he's got fatty liver disease, whichever test we're going to use. Okay, so is there any further testing you'd like to perform on this patient? Anything you can think of, Miriam, that you'd like to look at?
Not that I can think of.
Okay, so the only other thing I would probably want to do is an ultrasound. Just making sure. I know we have increased echogenicity. I just want to make sure I don't see any other tumors or anything in his liver. And how would I stage him? I would stage him as an F3 at this point. Okay, so how am I going to treat this patient? How do you want to treat this patient as an F3, Miriam?
Should I start thinking about maybe Resmetirom? Lifestyle
Okay.
modifications, exercise, watch the diet, obviously.
Correct. We're going to do the standard of care, which is diet, exercise, and medication. And then we have medications. And Resmetirom is one of those medications because he qualifies. Resmetirom, remember, right now is approved for F2s and F3s. And so we're saying he's an F3, so he definitely qualifies for that. Remember, the Resmetirom is only going to work for his fibrosis. What do you want to do about the CAP score? Do you want to do anything with that, with his diabetes? Still a little bit out of control?
Maybe consider the GLP-1.
Absolutely. You're going to think about those GPL-1s for him. There's a variety of choices. We know that Ozempic's been approved by the FDA for it. We know Wegovy's been approved for it for weight loss, but he has diabetes, so we really can use anything that we wish to use. We have to just realize that he needs to take an injection every week. Okay. How often do you think you want to monitor this patient?
Maybe every few weeks.
Why?
To monitor his LFTs.
Okay, well, we're not going to monitor his LFTs every few weeks. We can do those every couple of months. They're not going to change that significantly. But every couple of weeks for maybe the first month to 2 months. And reason being is because we're making a big change in his life. We're giving him medications. We're watching his blood sugars at this point, making sure he's doing what he needs to do. We want to talk about his diet each time he comes in. What we find in our practice, and I can only speak for our practice, is I ask you, so what do you eat for breakfast, Miriam? What do you eat for lunch? What do you eat for dinner? What do you eat for snacks? And what do you drink all day? And so based on what you tell me, I'm going to tweak your diet just a tiny bit. We don't tend to give you, here's a 1,500 calorie, a 2,100 calorie. We don't tend to do that. And part of the reason we don't do that is nobody eats the foods on there anyways. So we take what they normally eat so they don't have to make major changes in their life, but it's making simple changes. I work in 2 different environments. One is basically Hispanic and one is basically Iraqi. If you're in the Hispanic group, you tend to eat a lot of tortillas, so I cut you back 1 or 2 tortillas every couple weeks. So now we're down to a reasonable amount because they eat 10, 15 tortillas a day. If you're in my Iraqi group, they tend to eat a lot of bread. Now they switch to brown bread, not necessarily good brown bread, but they do switch to brown bread. So we just talk about eating half of the bread that they eat because they eat bread for every meal. At least that's been my experience. Okay, so we're going to monitor, like you said, every couple weeks for maybe a month or 2, and then we're going to go to every month or every 2 months, and then we'll go to 3 months. We kind of have the patient kind of help decide how often they need to be checking in. We check in first a little bit more, and then we're going to spread them out a little bit more. As they start to lose weight, I also tell them, I said, I don't want you to lose pounds. I want you to lose inches. We monitor their iliac crest so that we can see a 1/4 of an inch, a 1/2 an inch, not a lot, but they can see things and see that their clothes are fitting bigger because they're not just going to drop pounds right away. We have to tighten up that fat. All right, again, just like you said, we start Resmetirom, we modify their lifestyles, we consider the GPLs, and we still have to monitor for HCC, which is hepatocellular carcinoma. And the reason being is we're finding that our fatty livers are developing HCC sooner than cirrhosis. So we monitor them usually once a year, get the ultrasound and get the alpha fetal protein just to make sure we don't have any tumors or anything that's going on with them. All right, so now we're going to take that same patient, we're going to make him worse. He didn't get better, he got worse. Again, still has the same disease process, still has the same BMI. He doesn't have any of the palmar erythema, the spider hemangiomas, and he doesn't have the astera, so he has no stigmata yet. So he's early cirrhosis. Okay, blood pressure's borderline getting up there, so we're going to have to think about that. We have respiratory rate, okay, temperature, vital signs. Numbers are still the same, except this time his platelets have gone down a little bit and his bili climbed just ever so slightly. So I still don't know whether the bili is related to the Gilbert's disease because he's Caucasian. Could be, so I would have to order a direct bili to see that. But his platelets have dropped. They are now considered cirrhotic. His creatinine slowly climbing. So we're good. All right, same patient, but he has different NIT scores or VORUS. So now we look at it. Now all of a sudden his Fib4, if we did a Fib4, is definitely high risk. His K-Pascals on his FibroScan have gone up. He's definitely advanced fibrosis or an F4. His ELF test or his CAP test first is 245. Notice that it went down. As you have cirrhosis, you burn out the fat. So the fat score, the CAP score will go lower. It doesn't mean you've gotten better. It just means your liver is now burning the fat out. And then we have an ELF score that is very high, again, indicated of cirrhosis. So the CAP score by itself doesn't tell me anything. I need to have the K-Pascals with it. And you get that when you do a FibroScan, both scores. So is there any further testing you'd like to perform on this patient?
I would order an ultrasound and
Okay.
screen him for cancer, liver cancer, or AFP.
Okay. We also have to think about an endoscopy. He's now cirrhotic. We need to know if he has any esophageal varices. So
Yeah.
when we get to the F4, it really needs the hepatologist because that patient's gotten worse. So we have fatty liver with cirrhosis. And so we've got to combine those two to take care of both components of his liver disease. Okay?
Right.
All right. And then how do you stage him? We already said we're a stage 4.
Yes.
So we have done that. Okay, how are we going to treat this patient? I think you did a very good job of already telling us. We're going to get his alpha fetal protein. We're going to do the ultrasound. We're going to look for esophageal varices on this patient. This patient's going to get monitored absolutely every 3 months. We're not going to send him out anymore. But if his numbers change, let's say we're going to get his lab work done every 3 months. Hi, Renee. Every 3 months when we do it, we're going to have to watch those. If those keep going lower and lower or other things change, we're going to have to bring him in the office more often because of the cirrhosis, not because of the fatty liver. So it depends upon what those do as to how often we're going to monitor this patient. But we start out every 3 months. Okay?
Yeah.
Renee, would you like to introduce yourself?
Hi, everyone. I'm Renee Pozza. I serve as a hepatology nurse practitioner with Anna in Southern California, GI and liver centers.
All right.
And Anna, can I ask you a question?
Sure.
If we are keeping an eye on this patient every 3 months, what do we have to do every 3 months? If we had already ordered the ultrasound, alpha fetal protein, we scheduled him for EGD to evaluate for esophageal varices. What's the next step if we did that already?
It depends upon what those results come back. Okay, that will guide us whether we have to send him back for EGDs because now we have banding involved in it.
Right.
Okay, so that will change what we do. Otherwise, the screening for esophageal varices, usually the physician who does the endoscopy, the GI who does it, gives us a reference that says he needs to be repeated in 6 months or he needs to be repeated in 1 year. Occasionally, they'll tell us every 18 months because there's absolutely nothing down there. So that's how the esophageal varices will go. For monitoring of cancer, we're going to do it every 6 months. Every 6 months we get an ultrasound. Every 6 months we get an alpha fetal protein. Every 3 months we get CBC because we need to know what his platelets are doing and his hemoglobin is doing because that can drop. And we also need to get a CMP because we want to know what his liver enzymes are doing, what his bili's doing, what his alkaline phosphatase is doing, so that we can see when we start to have some changes so that we can take care of the patient. So there's not a really set answer. It all depends upon the patient. It's also a way to kind of just check in with them and see how they're doing for every 3 months. Doesn't have to be a big visit, just a little visit. So let's say we get his CBC and his hemoglobin is starting to drop, but we know we have no varices. And this guy's 55 and he says, no, I don't think I'm bleeding anywhere. I have stomach aches once in a while. I have a little bit of constipation. I think my hemorrhoids are acting up. What would you think you would like to do?
We need to check in for colonoscopy.
Correct. We would check the colonoscopy and see what's going on there, which has nothing to do with his liver disease, probably. It has everything to do with just he's constipated for whatever reason. And make sure he's drinking enough water, make sure he's doing some walking, make sure he's getting enough vegetables. Okay?
Yeah.
Okay. All right. So now we're looking at the differences between patient A and B. Renee, you want to go over it?
Yeah, I think these two patients, or it's the same patient with different lab values, it really is the importance of identifying these patients early, because you definitely have more treatment options for the individual with his scores of our case 6A, because we've got if you look at this, a FIB4, which I'm sure Anna outlined here, is looking at platelets, age, AST, and ALT, and gives us a score of an intermediate risk of fibrosis. An ELF score is a confirmatory test. If you have the labs, you can order an ELF test. Not everyone has access to this particular score, but you can see the difference if the lower the score in patient, or the 6A versus the 6B. And then for those of you that have access to FibroScan, I think this is a great way, the transient can't even say that word, FibroScan, right, to see your CAP score. And obviously early on, our CAP score was 11 with a kilopascal of the 6B, then going to 21, indicating advanced fibrosis and cirrhosis there, with the CAP being the amount of fat in the liver being essentially unchanged at that point. So definitely you have more options for patient earlier in disease process than when you're dealing with more advanced fibrosis.
One of the comments that Renee made is she says, if you have access, ELF scores right now, we know we can get them through Quest and LabCorp in California. So you have to check your labs. We have other labs that do not do them. So that may or may not be accessible to you. Sometimes your MAs can get prior auths for them to go to an outside lab, but you'll have to work with your staff to do that. And transient elastography, note, it really has to do with the skill of the person doing the exam. So you need to look at that as well. All right, some discussion points is, how do these two patients compare in management? I think we kind of gone through it, but again, like Renee said, F3s have a lot more options. We can put them on the Resmetirom, Miriam, that you asked for. We can put them on the GPL1s. I can put a F4 on a GPL1, but right now I cannot put them on Resmetirom. It is being tested right now. It is in clinical trial to do that, but it has not come out approval of the FDA at this point in time.
Okay.
Staging between 3 and 4, we went through the different serum lab values, and we went through the imaging values. When you have intermediate or indeterminate NITs, we sometimes have to consider a liver biopsy to get a better score for us. And when is HCC surveillance important? HCC surveillance is important always. As I said at the very beginning, we are seeing F3s getting HCC. We definitely have to scan it for F4s because they are cirrhotic, and cirrhotics are known to have HCC earlier or have it while they have the cirrhosis of the liver.
So you said do AFP every 6 months for everybody, like F3 and F4s?
No, F4 gets it every 6 months, and F3 gets it once a year.
Once a year.
However, if I order, let's say I order an ultrasound there was an ultrasound for some reason, not ordered by me. Maybe they thought he had just something and it came back with a potential mass. I will order an AFP at that point.
Right, right.
And then I will put him on a 6-month ultrasound for me.
Yeah, I just had one of those today, actually. I just was scanning through his history, and he came in initially for rectal bleed. And suddenly I see PCP that wrote like a couple of sentences from 2023, liver mass, ultrasound was done, and CT, but nobody followed up on it. Ooh. So I ordered the MRI and the alpha fetal protein, CBC, CMPs on him.
Very good. Good pickup.
Yeah.
The other
that's
thing,
a good point. Just going to say that I think you want to surveil with some kind of imaging. And so Anna mentioned ultrasound and an alpha fetoprotein every 6 months. If you have someone that you're concerned or has a history or a family history, I think you can alternate and consider a CT, a triphasic CT, or an MRI, so that you're alternating and using the CT or MRI as part of your surveillance imaging, and not just rely on ultrasound.
Okay.
Yeah, I think that's really important to know. Okay. The other thing is if you have someone with colon cancer, get an abdominal ultrasound. Colon cancer frequently will metastasize to the liver.
Yeah.
Okay.
Yeah.
All right. You get to visit the GAP, looking at MASLD and NASH Community Network for additional disease information. There's also a Resmetirom webcast there for you. Please scan this, and we'd appreciate any feedback that you have. Your insights help us continue to improve.